Hello, everybody, and welcome to In Conversation. This episode is a special edition of Intellect's regular podcast, brought to you in collaboration with Doctors Rupal, Shah and Jens Foell. Jens and Ru are, of course, the authors of Fighting for the Soul of General Practice, The Algorithm Will See You Now. So, thank you all for your time today. I'm very much looking forward to hearing from each of you. And of course, we are joined today by Doctors Marleen Kunneman and Victor Montori. It's an absolute pleasure to have you both on the podcast. And it'd be great just to hear a little bit about who you are and a bit about your research backgrounds. Marleen, can I please start with you?
Yes, absolutely. And thanks for the invitation. I'm Marleen Kunneman. I'm a researcher and university teacher at Leiden University Medical Center in the Netherlands and also at Mayo Clinic in the US. And I focus on patient-clinician collaboration and communication. I'm a linguist from background. And I do research how to improve decision-making about health and care for each individual patient.
Thank you very much. And Victor, just give us a quick intro to who you are and what your roles are as well, please.
Yeah, Victor Montori. I'm a physician, take care of patients with diabetes at the Mayo Clinic in the United States. And I work promoting careful and kind care for all as part of my role at the Patient Revolution. And I'm a collaborator with Dr. Kunneman in work to advance the processes that we use in clinical practice to make care fit.
Okay. Well, thank you both for those introductions. As a publisher, I'm fascinated to hear a little bit more about your background as a linguist and how that affects your research. And maybe you can sort of jump in and give us a few examples of that as we discuss these topics. But of course, I'm very interested in this notion of humanistic approaches to collaboration, and of course, your work around the Making Care Fit manifesto. And beyond that, I was fortunate enough to have a read of your paper, Measurement with a Wink, and I love some of the analogies there as well. So perhaps we could start with just unpacking a few of these different things. So could you tell me a little bit about the Making Care Fit manifesto, Marleen, and then maybe sort of link that to the paper, Measurement with a Wink as well?
Yes, absolutely. So the Making Care Fit manifesto was published, I would say 1 or 2 years ago. It was an initiative of an international and interdisciplinary group of people. And we invited all of them together over the course of 2 days to reflect on what the necessary conditions are to make care fit. So we had representatives of patients, of loved ones or informal caregivers, clinicians, healthcare designers, researchers, and we wanted each person to have a unique expertise, either personal or professional. So we used several methods, and then in the end, we wrote this manifesto where we say that we need to make sure in the work that we do, each from our own area of expertise, that our care plans, our care maximally responds to the patient's unique situation, and this is both personal and medical situation, but also to their priorities, while at the same time minimally disrupting their lives and things that make life worth living in the first place, and their social networks. And this is an ongoing and iterative process of collaboration, both in the content and in the manner, in the way people work together, of having unhurried conversations. And this is what we focused on. And it has been, to me, a starting point of a new focus in research, where we also wanted to see what is happening in practice, what do experts think, what do we see in research already. So it's been a great starting point to dive into this topic of what is making care fit and why do we want to do this.
Thank you very much, Marleen. Victor, I would love to hear a bit of your take on this as well.
Yeah, I'm a clinician that takes care of patients with chronic conditions, and there's this tyranny of evidence that tells us that for these patients, we have to optimize the control of each of their conditions. And as we know, patients with chronic conditions tend to accumulate more chronic conditions, and the more disadvantaged they are, they tend to accumulate them at an earlier age, including conditions not only of physical health, but also mental health. And so as we try to figure out how do we make care plans with them, not for them, but with them, we have to think about their, what is the content and quality of their life, and how do we make sure that not only this quality of their life is not affected to the extent possible by the disease and illness, but we also have to make sure that it doesn't get affected by our care, by our treatments and tests. And this is, I think, what Marleen and her colleagues have been talking about, making the care fit for each person. And in doing that, help us understand the importance of not delivering care to people, but forming plans of care with people, and not to advance the goals of the healthcare system, but to advance their goals for life and healthcare. So it's absolutely essential reframing of what the purpose of care is, particularly for people that live with, 2 or more chronic conditions, 8 or 9 medicines, and a lot of different cooks in the kitchen, so to speak. And at the same time, none of them trying to be the best patient, all of them trying to live their lives to the best possible extent.
Thank you very much. I was also interested, Marleen, if you're working between Europe and the US, has that affected your research and your thinking on these topics, or is that sort of irrelevant to you?
No, I think it is relevant in many ways. So first of all, I think it's a great opportunity to work in several teams and to get inspired by multiple people. It's very interdisciplinary. So that's very motivating. And I'm very lucky to learn every day in what I do. And then second, they're very different health systems. So it's also good to reflect on how relevant is the research that I'm doing. And I need that motivation. So I'm a researcher that I would like to see tomorrow what the effect is of the work that I do today. And that's very difficult for a researcher because it usually takes a while. But understanding the systems that we work in and understanding the relevance of the work that we do really makes you see that when I look at making care fit and the manifesto and the work that I do, that some of these topics are especially relevant in the US. As an example, when we're talking about sensibility of care plans, that is one of the outcomes that I would like to look at. So how sensible is a care decision? And we can talk about rational sense. I understand that it's the right decision. We can talk about emotional sense. It just feels right. Or we can talk about practical sense. And actually the practical sense in the US, cost, for example, was the #1 issue raised in one of the biggest studies that we did. And that's something that I would not have seen in the Netherlands because their cost, well, we have a different system. So that would not be raised as often as it was in the US. But it also means that we sometimes make decisions and we think that it will fit. But as soon as that person leaves the consultation room and goes home and finds out what the cost of certain treatments are, they may not be able to even fill their prescription. And then, we get to label those people as non-adherent or non-compliant, while in fact, we made a decision that just didn't fit well.
Thank you. And talking about fitting well, Ru and Jens, it would be good perhaps to get your perspective here as well, and how practical this way of thinking might be with the work that you're doing in the NHS. Ru, what are your thoughts on that?
It's so relevant. I'll give you an example. So last year, one of the prescribing incentive schemes that we all had to sign up to was to offer statins to everybody with chronic kidney disease. There's 2 things here which really resonate with Marleen and Victor's paper, Measurement with a Wink. So first, we're incentivized to code chronic kidney disease, but not to incorporate it into care plans. And so a lot of people who are coded with chronic kidney disease don't know they have chronic kidney disease, particularly people who are in their 80s, 90s with sort of a minimal kind of reduction in glomerular filtration rate. So it's mild kidney disease, which is not going to have prognostic implications. And so then to offer everybody with chronic kidney disease a statin, you can imagine what happens. You've got people, typically our lovely pharmacy team, phoning patients they've never met and saying, because of your chronic kidney disease, you need to have a statin to control your cholesterol. And it's absolutely ludicrous. People are very upset to be told they have chronic kidney disease. They don't know who they're talking to really, because it's quite anonymized. It's on the phone. They haven't met the clinician telling them this. And so in terms of making care fit, I think it's a really good example of how not to make care fit on many levels. And I think it's a very real example, which we were doing just last year. And so I'm really interested in how we can incorporate Marleen and Victor's work into considering new incentive schemes like this.
Thank you. And Jens, how about you? Do you have thoughts or experiences of this in action?
Many thoughts, and I would say that we are with the British training, we are very well equipped to find out what the lived experience of the patient is and to navigate the tension between the incentives. Often our payment is linked to the meeting these incentives and managing this conflict, because on one hand we have to address population averages and have a sales pitch to sell to patients when they have heart failure. Oh, you need another agent, you need gliflozin, but if you take this, you have to be aware of Fourier's gangrene and thrush, and have a sales pitch in this way, or on the other way around, saying what is at stake for this patient. How do their lives look like? Is this really important? And how important is the relationship with us when it comes to the end of their lives, to have maybe fewer medication? And I think on the whole, our training is fantastic in doing this, but the financial incentives in a cash-strapped system are counterproductive to this. So we are having to make moral injuries or moral decisions and carrying moral injury with us, because what we are paid for is not reflected in what we are doing with the patient. We are doing this very well, I think, and depending on our practices, in some practices there is the incentive that the incentive is very dominant, and in other practices you go with the patient and work together. And I have in my practice found that if you work together with people, it works very smooth, rather than cold calling and having initiatives, last minute calls, etc. That I don't see that working very often.
I think a big problem is how you quality assure this. So, in Scotland, for example, they got rid of the quality and outcomes framework in 2016. And so practices are encouraged to target local health needs in collaboration with one another, which is fantastic. But I don't think they've worked out how to quality assure it. And that's a big question. So if, for example, instead of being rewarded for prescribing the statin or the gliflozin, we were asked to make sure that everybody had a heart failure review, you can see that there'd be a lot of gaming of the system. You kind of wonder whether, I suppose whether you can trust clinicians to do the right thing if this scrutiny is removed. So interested to hear what people think.
Yeah, I think that's a good point. Marleen, what do you think about that?
Well, it's a challenge, right? Because at some point, getting a high score on the measure becomes the goal. and not so much the behavior that we are trying to measure. And I think that is one of the things that we wanted to highlight with the measurement with a wink paper. I was actually just following a Dutch TV quiz, and it was advertised as being a knowledge quiz with a wink, because the show's smartest person wasn't necessarily the most knowledgeable person. It was the one who knows best how to play the game and how to get the points. And we saw this parallel with healthcare. And in the paper, we focused on basically two, well, incentives or way of rewarding that could be misleading. And then one is what I just mentioned, knowing how to best improve the score without necessarily improving the underlying behavior. And then the other thing is also over-reliance on proxy measures. And so for example, in shared decision-making, the number one outcome in shared decision-making studies, so these are studies looking at how patients and clinicians collaborate, the number one outcome is actually patient knowledge. So is knowledge the one thing that should improve when we involve patients more in our encounter? Is that a suitable proxy measure for shared decision-making? Yeah, so we focused on those two things, and I think we need to make sure, as we routinely measure a lot with patients. I think they spend like 10 or 15 minutes for each encounter, filling in questionnaires on their outcomes and their experiences. And what do we do with all these measures, and how can we interpret them? And I think we want to do a lot, but sometimes we don't know what is actually best and what matters most to patients. So if we want measurement to drive performance, what is the performance that we're looking at that needs to be improved?
And also, how do you develop measures whose importance you can improve, regardless of who the person is? And I think that is a key factor here, is that each person benefits, struggles, and enjoys being heard and seen in their own problematic situation. But to be judged as a clinician across the board, what matters is the things that you can generalize across people. Well, those things also probably matter much less to each of the people that you're there. And so if those, as Marleen said, drive your attention and drive all the efforts for quality improvement, is not to improve the quality of what you do, but improve the extent to which you make the measure better, then what gives is your ability to co-create with each patient a plan of care that, as Marleen said, would make intellectual, practical, and emotional sense to each one.
I think a big step could be making the data entry a joint project. I see that sometimes when I deal with people with pain, trauma, etc., when it comes to coding what it actually is, how this person gets represented in the data world, and having shared or joint ownership of the data, I think is a very noble process. And saying this is something we need to do, it probably takes 3-4 minutes, and that is something where I'm judged and you are judged. I would like that. If I imagine I have a 10-minute consultation and the data generation is something where we do it together, maybe share the screen, and not having this as a dual entry where I'm listening and looking at the same time, saying this is important. Your life is represented in here. Our work is represented in here. It really, really matters. That's what I would like to see.
I completely agree. I think that is the conversational dance that we're looking for. And whether that is represented on a screen by a list of questions, or it's just genuine interest, curiosity of who is this person sitting in front of me, I think it's necessary to have those conversations. And I also think that those conversations should be about more than just what are your preferences or what are your values. It should be about, what if you go home, what makes you happy tomorrow? What are the things that you would like to do? And these are questions that we rarely see being asked in encounters. And at the same time, we need to bridge whatever happens at the point of life in patients' own personal environments, what makes them happy, what they would like to achieve in life or would like to continue doing in life, and how can we adjust care to that. But we need to bridge what happens at the point of care with, or at the point of life with, what happens at the point of care. So what is discussed in the clinical encounters? And that may be about, well, here are the benefits and harms of treatment, and do these matter to you? But why don't we turn that around and just ask the question, what does your life look like? What kind of person are you? What gives you joy? And then try and see how that aligns with the options that we have available for this person.
This to me sounds like a wonderful approach, a person-centered approach. But is it workable at the scale that we need it to?
That's a good question, and I'm not sure. I would like to believe it is. I'm not sure how to do it. Let's state it like that. So my take on this is that we start small. We start with, what can I do today? What kind of conversations do I have today within the system that we have? What is possible? And just take one step at a time in improving these conversations, so that at the end of every encounter, you can say, well, at least we tried. And I think we worked towards something that made sense for this person. I
have two thoughts about it. One, I see the tension between the doctor as a craftsperson, the craft, bringing people in, building connections, often by silence, I would say, rather than asking questions, by inviting people. And if they're invited by silence, which is a meaningful silence there, that's often a miracle. And the silence also needs a kind of garden in which the silence is allowed. So practice culture and knowing to get to work towards face to face, to side by side. Is this always the question in the NHS? Can this be rolled out? Is this generalizable? Can it be standardized? Of course not. Nothing can be done in this way, but with local experiments, little gardens, little experiments, I think a lot can be done. I'm quite positive about that, and I don't think you need more time or time itself. I think it mainly needs another attitude and flourishing and nurturing, and I see that happening all the time.
In terms
Thank
of
you, Jens.
stability, my comment would be, what's the alternative? So the processing of people, ignoring their particularities and focusing only on what they have in common with other people with the same diagnosis, often leads to the accumulation of treatments that are not feasibly undertaken in people's lives, the use of people's energy, time, and attention as if health was the only goal they pursue in their life, their individual goals, and their over-reliance on medical technologies, treatments, and tests to advance that goal at the expense of everything else that makes life worth living. And that is a form of medical intrusion in people's lives, of medicalization of every aspect of life, that does not contribute to a sustainable response to people's challenges from a health challenge perspective. It's not sustainable for the humans involved in care. It overwhelms clinicians. It overwhelms healthcare systems. It creates waiting lists. It creates long lines. It creates delays for people who are sick. It overwhelms the environment. 5% of greenhouse emissions and carbon emissions are from healthcare, and that's likely to continue to extend if we just keep doing more tests and treatments on people and demand more data for each one of them, so that we can individualize on the basis of their data, not on the basis of who they are and what they're pursuing in their life. And it's also not sustainable from a financial perspective, the cost associated with simply responding to disease features without taking into account the rest of the situation of the patient, the rest of their psychosocial and context, and where they've been and where they want to go, means that we just keep adding on. And the healthcare inflation at the individual, community, society, and planetary level that entails will be simply unsustainable. So what's the alternative? The alternative to patient-centered care is not sustainable. So we need to make patient-centered care work. And I think to make it work, the temptation is to over-reliance on technology. The answer is a reliance on relationships. And the basic fundamental innovative trick that we have to master in healthcare is how do we create the space for those relationships to work at scale. And I think the healthcare organization that masters that, one of the first signs will be in their ability to foster unhurried conversations that Marleen mentioned, unhurried conversations to make care fit. If an organization can do that, then the other organizations will only have one choice, and that is whether or not to imitate what they did to make that work.
Thank you very much. Very interesting insights from all of you there. I'm happy to say that Dr. Rupal Shah has rejoined us. I don't know how much of that you caught, Ru. Just wondering whether you had any kind of final thoughts on this topic. Perhaps in conclusion, if there's anything you would like to see change, or what you see as the potential ways through this.
I can't see a way in which we can remove targets altogether, and rely entirely on trust and the willingness of all doctors to make care fit. But maybe we can be more creative with how we use targets. I was listening to a podcast featuring Laura Nielsen, founder of the Hope Citadel, recently, and her foundation aims to tackle health inequalities in deprived areas of Manchester. She suggests that we should look carefully at data about people who don't engage with recall and make a special effort to understand why, to think about what else might be going on for them and their families, and make a personalised attempt to contact them by telephone. I think using targets in that kind of way makes a lot of sense to me.
Jens, any final thoughts from you?
Definitely. Not rely on surveillance that fits for me very well, and building bridges and relying on good relationships, because that has been shown so often that this is important. And I see time and again that good relationships with their physicians keeps people alive. I can even look at my mom, who, when she had final terminal cancer, maintaining the relationship with her GP made her choose a nursing home that is close to the GP, not moving to a hospice further away. And that was by no way engineered by myself. It was an appreciation that this was really important for her. And I see it time and again, if people need it, how important a relationship with the GP is, possibly, or with a family physician, with a relational continuity, particularly if you look at severe mental health, palliative care, a situation where complexity reduction is really important, and you probably need this person to reduce the complexity, the relationship itself as complexity reduction. That needs to happen, and it works.
Thank you. And Marleen and Victor, one of the things I really enjoyed about dipping in and out of your research and various papers of yours that I've encountered is that they're very easy to comprehend for a layperson. I have no experience in the medical healthcare profession, so it's been a delight to kind of read it and sort of understand some of the perspectives that you're putting out there. They're very relatable terms. And I guess I can hear some of your background as a linguist as well, and some of the analogies and sort of examples you use. So the audience today, many of whom will, of course, be general practitioners and medical professionals, but there will be other people joining us who, are lay people such as myself. And I was just wondering, do either of you have any final thoughts on this in conclusion that, might leave a bit more hope in the sort of the hearts and minds of the general populace, who of course have to interact with their GPs, and some of this, well, I think the day-to-day language that they encounter is probably quite disturbing, but the way that you all talk about it, I think, is much more encouraging and far more humanistic. So I appreciate that. But yeah, perhaps if you could just share any final thoughts with us. Marleen.
Yes, thank you, James. Great compliment. I really hope that what we do does not only reach the researchers and the clinicians, but also people interested in this topic and people who are seeking for signs of care. And also, Jens, hearing your example, I think that is exactly what it's about. Care is something that we do. It's a verb. It's not something that we deliver. It's something that we do with people, and it's something, if you have a relationship, if you care for someone, you can fall back on that relationship whenever there are setbacks in life or in care, when treatments don't work, when you have to think of other options. So I would definitely agree that building and maintaining that relationship is the core of care.
I'm not an optimist. An optimist is someone who thinks that the world is going to get better no matter what we do. But I have hope, and the hope comes from the work that we do. By we, I mean the people in this conversation, in writing, in thinking, but also in doing experiments and then disseminating the findings and trying to change the way people speak and write and think and do. It is through that work of change that there is a possibility, perhaps small, but a possibility that the future will be different and hopefully better. And that is what gives us hope, is the work we do today. And to that extent, I think I would invite people to join work that is happening, including what I'm involved in with Patient Revolution, that by taking steps today, creates the possibility that perhaps the future will be better, that there will be more room, more opportunity, and more ability for people that follow us to enjoy person-centered care when they need it the most.
Well, thank you all very much for your time today and for those insightful and somewhat optimistic answers. I very much appreciate it. It's been wonderful having you all in conversation today. Thank you all greatly for the work that you do. And I very much look forward to continuing reading the research that you're putting out there in the world as well. So thank you again. It's much appreciated.
Thank you, thank you, thank you.
Thank you, James. Thank you.